Hello and welcome everybody to the June edition of the Canadian Obesity Network's public webinar series. My name is Dawn Hatanaka and I'm the Education Director for the Canadian Obesity Network and your host for today's discussion. This series is just one of the ways that the network disseminates credible and useful information about obesity to Canadians. And if you'd like to be part of our growing public community and want to be first to hear about future public webinars and other events, please go to obesitynetwork.ca/public and opt in for our newsletter. An archive of this webinar will be posted and available for viewing on the obesitynetwork.ca webinars page, where you can also check out previous editions. Please note that due to the extremely high volume of requests to join this presentation, we have disabled both microphone and question and answer features. However, we do want to answer any questions you might have, so if you have any questions you'd like to ask our speaker, you may do so via social media or in the evaluation survey at the end of this presentation. Please take a few minutes to fill that out. Your feedback will help us guide future webinars. And now it's my extreme pleasure to introduce you to today's speaker, Dr. Sean Wharton, who is a longtime supporter of the Canadian Obesity Network, and he's here to discuss obesity treatments in Canada. Dr. Wharton has a doctorate in pharmacy and medicine. He is the medical director of the Wharton Medical Clinic, a community-based internal medicine weight management program. He is an adjunct professor at McMaster University and York University, and he also works as an internist at Toronto East General Hospital and Hamilton Health Sciences. Dr. Wharton's research focuses on bariatric medicine and type 2 diabetes. If that wasn't enough, he's also the lead author of the weight management section of the 2013 and 2018 Canadian Diabetes Guidelines. And with that, I'd like to hand it over to Dr. Wharton.
Thank you very much, Don. This is terrific. I'm really pleased to be presenting this webinar series. I have been a supporter for CON since the very start, and I believe that reaching out to the public is going to be a very important aspect, as there is a lot of interesting information and science that is evolving in the weight management field. So I'm looking forward to having a discussion with a number of people about these various topics. So great, my talk today, I'm going to look at the treatments in obesity treatments in Canada. What are the current options that are available? So here are my conflict of interest slides in terms of the grants that I've had from an academic standpoint, the honorariums and the different companies that I have worked with, and where I am currently working. There are no financial disclosures for this talk. Now, if we look at Canada, in terms of the number of people that are struggling with weight, it's no surprise that Canada is almost, it's near fifth in the world in terms of the number of people that are struggling with weight. So we're going to likely see a tripling of obesity in Canada, expected to strain the healthcare system as we move into the 2020s. And the group that has had the highest amount of rise is the obesity class 3 group. You can see that light blue line there is the line that is the obesity class 3, and that is the group that we classify as the highest weight in Canada, and that group has been growing faster than any other group. Therefore, we definitely have our work cut out for us. So if it was just about the physical weight, then there would probably not be as many problems as we think. But unfortunately, the weight attributes to a lot of other medical conditions, including coronary artery disease problems, elevated cholesterol, high blood pressure, and diabetes. And recently, we've been finding there's been a strong connection between elevated weight and cancers, including breast cancers, uterine cancer, and colon cancer. Gallbladder disease is also common, and so is non-alcoholic fatty liver problems is also a major issue. Now, let's discuss a little bit about why there's an elevation in weight, why we've been continuing to see this particularly over the past about 20 to 30 years. Well, we know from an evolutionary standpoint that all people have to be able to to eat more food and to be able to store fat. So this was a simple study looking at patients where we gave them increased amount of food on a day 1, 2, 3, and 4. As we increased the amount of food, everybody was able to eat more. Some people ate a little bit less than others who were able to eat even more, but everybody overall could take in more food. So there's an evolutionary aspect to us being able to hang on to food and store it. And because of the availability of food over the past 20 to 30 years, that evolutionary part of our human nature to be able to take in more food has caused a significant increase in weight. So now that we have this condition where more and more people are increasing their weight, let's talk about how we can try to either stop the weight from going up further or get the weight down and try to keep it down over the long term. So the most important slide in this slide deck is this one here, which states that obesity is a chronic, progressive, and relapsing medical condition. And chronic means that whatever weight a person gets to, their highest weight, they'll likely stay there, and therefore coming back down in weight is very hard. And if we could stop further weight gain, that is an important thing. So the chronicity is always there. The progressive nature, everybody gains a little bit of weight every single year. If you could gain a tenth of a pound every year, that is pretty good. But if you're prone to gaining a pound, 5 pounds, 10 pounds every year, you could be in more trouble. The relapsing nature, we know that this condition, if somebody does decrease their weight, their chance of relapsing very is very high. So that's these are the three important things: chronic, progressive, and relapsing medical condition. And Charles Dickens, many years ago, said, "Subdue your appetites, my dear, and you conquered human nature." Even at that time, Charles Dickens was aware that decreasing your appetite and keeping it down for a long period of time is very challenging. And why is it so challenging to keep our appetites down or to keep our weight down over the long term? And this is because of this issue here. And this is the second most important slide in the slide deck. The biology of our body is to defend your highest weight. So whatever weight you have got to, your top weight, and particularly if you're there, if you have been at that weight for a long period of time, then then your body will always try to get back up to that weight. Now the question is why would your body want to stay at a weight of 250, 350? Well, if we look at the evolution of this, back 5,000 years ago, if you were 110 pounds and you decreased your weight down to 85 pounds and you stayed there easily, that would be a problem because you wouldn't be strong enough to go and catch the next water buffalo. So the aspect is that you want to get back up to 110 pounds or keep the weight as long as you could so you could survive the famine, you could be able to go and hunt properly. Unfortunately, that same evolutionary and biology process is there when your weight goes up to 150 to 200 to 250 to 350. So that same sticking to that highest weight is there regardless of weight you end up getting to. Now, because many people believe that they can decrease their weight with just lifestyle modifications, we want to take a look at that biology of getting back to your highest weight. Now, this is a meta-analysis done in 2001. There were 13 studies. So they took 13 studies and they grouped them all, and they took a look to see whether patients could decrease weight over the long term. Now, these patients were in lifestyle modification programs. They're exercising more. They're being given some liquid dietary shakes, and they're counseled. And over a 6-month time frame, these patients lost 14% of their weight, which is pretty good. But the question isn't how much weight you can keep off in 6 months, because just about anyone can lose weight over a month, a couple months. But could you keep the weight off over 4 to 5 years? So what percentage of patients do you think were able to keep their weight off over a 4 to 5 year time frame? I'm going to give you a second to think about that. 1, 2, 3. And now I'm going to give you the answer. It was 3% of patients were able to keep their weight off, or about an average 3% weight loss in these patients. So we can see that the majority of patients regain weight. But um, because we believed we didn't really want to believe that concept, let's talk a little bit about what drives this entire thing. Because many people will try more and more diets because they believe that the next diet is actually going to work. Let's talk about hunger. Hunger is the reaction to a low level of glucose. And if you can't shut off hunger, your weight ends up going up. Now, most people can shut off their hunger relatively easily by just eating food. Um, uh, but there are some people where the hunger can last for long periods of time without it being shut off. But the bigger problem is our appetite. Your appetite is your desire to eat extra food and to eat food that either looks good, smells good, and can be high in calories. And that's a complicated biological and neurological aspect to understand appetite. Now, most people have the most trouble with this aspect and cannot shut off their appetite properly. So let's talk about the shutting off concept, and that's called your satiety. The satiety is the feeling of fullness, feeling of satisfaction, and if this isn't working, then your weight goes up and up. So let's talk a little bit about where the control mechanisms are for hunger, for appetite, and for feeling full. It all is involved in the brain, in the hypothalamus. So the hypothalamus controls this automatic functioning of trying to deal with weight, trying to adjust a person's weight. Now, we've, some people have heard about this concept of the set point, and there is actually some evidence stating that in the hypothalamus there's scar tissue that that develops at different weights. So whatever highest weight you go up to, we can see that there is an inflammatory process or gliosis that develops in the hypothalamus, giving us some evidence to believe that there is an actual set point. In fact, in animal models, we've been seeing that animals that live with the mother, if she has an elevated weight, when she's giving birth to the child, the fetus is actually developing scar tissue in the hypothalamus. So these fetus of an obese mom are already developing the scar tissue to hang on to weight in over the long term. So let's talk a little bit more about the hypothalamus and the hormones. So we have ghrelin is a hormone that's produced by the stomach. It goes to the brain and it makes you feel hungry. And here are a number of other hormones: amylin, insulin, PYY, GLP-1, CCK. All of these are produced by the gut and by the organs, and they also go to the brain to make you feel full. And leptin, produced by fat cells, also goes to the brain to make you feel full. So in essence, what you want is you want better functioning in your body of the hormones that make you feel full, and a decreased activity in the ones that make you feel hungry. Let's talk a little bit about leptin, because leptin is one of these hormones. So leptin is a good hormone that's trying to keep you thin, and leptin comes the from from the fat cells. Um, so when you eat food and you take that energy from the food and you put it into fat cells, the body says, okay, I have enough fat cells. I'm going to release a hormone that goes up to the brain that tells the brain to stop eating and to increase the metabolic rate. So the question is do people living with obesity, do they have a high level of leptin or a low level of, of leptin? So, and the answer to that is most people would think that the answer is they have a low level of leptin because clearly this hormone is not working to have them stop eating. It's not increasing their metabolic rate, and they're continuing to put more and more energy into the fat cells. But don't forget, leptin is made in the fat cells. I know people living with obesity lot of leptin. People living with obesity have a lot of leptin. So what's the problem? Why isn't the message getting to the brain? Well, the message gets into the brain, but it's not received properly. So there's leptin resistance. And we don't exactly know why certain people have a resistance to getting the message of leptin. But what this parallels to is to another medical condition called diabetes. Because insulin, people living with type 2 diabetes have lots of insulin floating around. The problem is that they are resistant to the insulin and then develop their diabetes. So you can see that obesity and diabetes are closely linked in their mechanisms and and their biology. Let's talk about bariatric surgery first, in terms of the treatment options. So we know that bariatric surgery is the most effective treatment for decreasing weight and eliminating or decreasing the medical conditions associated with elevated weight. So, so full stop, bariatric surgery is the most effective treatment we have for people with elevated weight. You can see here that diabetes goes into remission by almost 77% in patients going for surgery, and the other medical conditions also end up getting better. So the two types of surgeries that are most that are the gold standard in Canada are the Roux-en-Y gastric bypass and the sleeve gastrectomy, and we call them metabolic surgeries. The reason why we call them metabolic surgeries is because they cure metabolic conditions, and it's because these surgeries are neurohormonal surgeries. You should not think of them as restrictive surgeries, but more so as generating hormones that change the way our metabolic conditions are. And also available in Canada in some places is the lap band. The lap band does not work because there are very few hormones that are generated from the lap band. Therefore, it's primarily a restrictive surgery. As a result, patients end up regaining weight. Some patients don't lose any weight, and there's also very poor resolution of the medical conditions. So I do not recommend the lap band for any of my patients. So I want to talk a little bit about why the gastric bypass and sleeve gastrectomy are such effective surgeries for medical conditions. We know that on the day of surgery, if you have diabetes, your diabetes is resolved. So, and that's hard to understand because patients haven't lost any weight on the day of surgery. Um, but right on that day, if you're on insulin or diabetic medications, we actually stop those those meds. And the reason why we're able to do that is because of this concept. And this was a theory. It's no longer a theory, but up until about 15 years ago, we proposed that this is why there was the resolution of weight and the resolution of diabetes. You can see here that food can come into the esophagus and bypass the stomach and go into the small intestines. When it goes into the small intestines, semi-digested food hits the ileum. The ileum is the last part of the small intestines, and this is where the L cells live. L cells are cells that release hormones that tell the body that you have just eaten food. These are incretin hormones, and one of those hormones is called GLP-1. So when the semi-digested food hits the ileum and hits the L cells, it releases a flood of GLP-1. GLP-1 is a good hormone that goes to the pancreas and tells the pancreas, wake up, it's time to do the work that you have normally done, and and it increases the amount of insulin, it increases the functioning of insulin, and the diabetes goes away. This GLP-1 also goes up into the brain and tells the brain how to eat properly and how to handle the metabolism of, of food so that patients feel more full, and so they're not as hungry. There's a decrease in appetite and you're eating the right amount of food. So that's why gastric bypass surgery is effective for both diabetes and for keeping weight off long term is because of the hormonal changes, not because of the restrictive aspect of the surgery. So as I said previously, this was more of a theory, but now we know it's actually a fact. And this is a study showing that soon after um, bariatric surgery, there's a rise in GLP-1, good hormone, a rise in PYY, a rise in CCK. These are all good hormones, and a decrease in the bad hormones, ghrelin. So it is fact that bariatric surgery is having that hormonal change. Now, of course, we know that bariatric surgery is not scalable, meaning we probably won't be able to do it on all of our patients. All the people struggling with weight will not be able to get surgery because of multiple reasons. Therefore, we will look to try to find medications that are effective to decrease weight. And in fact, we have been able to find medications that have an effect. Remember, previously I was saying if we could increase the GLP-1, we can increase it with surgery, but if we could increase it by itself with another method, by giving the actual medication, that would work. And that's exactly what this medication is. This is a medication called liraglutide. Liraglutide actually is GLP-1. It's an injectable hormone, and it helps to keep weight off long term. So here's a study showing patients that lost some weight over a 2 to 3 month period where they were able to decrease their weight by about 6% just doing lifestyle modification, eating better, exercising more. And then at this point is when we added in the medication. You can see the blue line is the medication that was given, and the patient's weight fell even further and stayed off over the long term versus giving the placebo medication where the weight essentially didn't change much. When we stop giving the medication, you see the weight starts to float back up. So this is very effective that we're now seeing that there's a medication that can help decrease weight. How many medications do we have in Canada? We have two medications available for weight management in Canada. One is called Orlistat or Xenical. It was approved in 1999. And then liraglutide 3.0 milligrams, also called Saxenda, that was approved in 2015. In the United States, there are 6 medications. So we are somewhat behind the 8 ball here in Canada, and certainly we know that there's going to be more and more medications that will be available around the world, but also available here in Canada. Now, most of the medications that are new in the States work in the brain. Again, if the medication is not getting into the hypothalamus and having an effect on the feeling of fullness, it likely is not going to be a very effective medication. And so here again are some of the medications that are available in Canada and in the States, and you can see here the average weight loss for the different types of medications. All of these have not been approved, but certainly we see here is the liraglutide that's available here in Canada, and here's the Orlistat that's also available here in Canada. Now, I will state that the way that Orlistat works, or because we talked about how liraglutide works, it is GLP-1. The way Orlistat works is that it prevents the conversion prevents the breakdown of fat within the GI tract. We know that fat is the most calorie-dense macronutrient, so if you can prevent the breakdown of this fat, then decrease the absorption that goes into the body, you can end up getting rid of some of this fat. So the main way that you get rid of fat is through the GI tract. So therefore, the main side effect of this medication is a increase in stomach problems, including diarrhea and having loose stools. As a result, a number of patients do not stay on this medication over the long term. So the actual effectiveness of this medication is relatively low versus lower side effect profiles, that patients are able to stay on them longer, therefore having longer term weight loss. So orlistat is not a medication that I recommend to my patients. I do recommend liraglutide. Um, and this slide is important because it tells us that both pharmacotherapy and surgery improves the adherence to lifestyle changes. So just because we have surgery and medications, we're not stopping or tossing out the aspect of working hard to increase your activity to make better food choices. So we all know that lifestyle modification is still at the core of treatment, and the medications are only going to help you to stay on track better. So we know that the medication and surgery help to increase the number of patients responding to lifestyle. If there were only 3 patients out of 100 responding to lifestyle, maybe with the medication we will get 15, 20 patients. Um, it increases the magnitude of the response. If there was only going to be a 3% weight loss with lifestyle modification, maybe now if you add in medications, you'll get a 10% weight loss, or 15, 20%. So and increasing the duration. If patients are able to keep weight off for a 3-month time frame with just lifestyle, maybe they'll be able to now keep it off for 6 months or a year or a couple of years. And with bariatric surgery, we certainly know that weight loss can stay off for a good 10, 15 years. So this is one of the handouts that I give to my patients, which explains how bariatric surgery works. It explains that we do not recommend the lap band. We recommend gastric bypass and the gastric sleeve. It also explains that the hormones come from the GI tract after you've rewired it and go up to the brain and go to the pancreas to help make the long-term changes. This is the handout that I give in terms of the medications that are available here in Canada, an explanation of orlistat. Although it's not one that I recommend to my patients, I still give patients the information about this medication. And here is the liraglutide. This is the one that I more so recommend at this stage to my patients. And the hope is that eventually we'll have more medications here in Canada. Here is the blown up section in terms of how Denical works. As I said, it's about a 3% weight loss, and there's loose bowel movements that occur. And unfortunately, many patients cannot stay on this medication over the long term. And Saxenda or liraglutide, as I stated, it's a hormone called GLP-1, which is released naturally from the intestines to create a feeling of fullness. People living with obesity have low levels of GLP-1, and these levels decrease even further with weight loss, leading to frequent weight regain. Um, so, so the weight loss that's expected is approximately 8% weight loss above the lifestyle modification. And it's injected daily in the evening, and it can cause some nausea. It is an expensive medication, so the hope is that the patient either has an insurance plan to cover the medications, or many of my patients have been opting to pay for this this medication, particularly if they find that they are getting benefit. So in terms of the success of obesity treatment, we can look at the fact that lifestyle modification does decrease weight, but it's only at a small percent, and we frequently see the weight going back up after a shorter period of time. Medications enhance that treatment, and we see more weight loss, and the weight can stay off for longer, but eventually, even with pharmacotherapy, the weight starts to eventually float back up. Even with surgery, so surgery we see the most amount of weight loss, ranging at 20 to 40% weight loss, but eventually over a time frame, particularly over 5, 10 to 15 years, we do eventually see the weight rising back up, even for bariatric surgery. Now, I'm going to end up with a case. Now, this is a case of a patient who has been 183 kilos. 183 kilos works out to about 400 pounds. His BMI was 60, so that's in the morbid obesity range or the class 3 range. He had type 2 diabetes, obstructive sleep apnea, high blood pressure, high cholesterol, and developmental delay, which was relatively mild. Medication included metformin, glyburide, ramipril, and Lipitor. Now, Barry was very motivated, and he lived in a group home. Um, the support workers at the group home helped him tremendously to make sure that he got the right meals, that he was active, but he was the one who was motivated to make the change. He would come into the clinic once every 2 weeks and would continually work on making the lifestyle changes. He was very motivated and very, very pleasant. So with just lifestyle modification, eating better and moving more, Barry lost a significant amount of, weight. You can see here that he lost 80 kilos. 80 kilos is about 180 pounds. So he just did terrific. So we're all very, very proud of Barry. And after losing the weight, this is Barry. Um, so his he had obstructive sleep apnea, and his CPAP was turned down, so he didn't need as much of it. Diabetes was under diet control. He didn't need his medications any longer. So you can see he was just doing great. But if you can remember, I said that the most important slide in this slide deck is that obesity is a chronic, progressive, and relapsing medical condition. So what do we think is going to eventually happen to Barry? Don't forget he did all this with just lifestyle. Yes, unfortunately, Barry went back up in weight. You can see here at this point, Barry went back up in weight. And this was very sad for us, but we had an understanding of why. So at this point here, Barry moved out of the group home. He moved in with a roommate, and he got a job in a cafeteria. And it wasn't the job in the cafeteria that actually caused the problem. It was more so the fact that he was living life the way many of us have to, which includes going to work on a regular basis and having other responsibilities and not being able to focus 100% of the time on losing weight. So during this time frame where he was losing weight, he was spending 100% of his time working on decreasing weight. Now that he's working, he had less time, and as a result, the weight floated back up because the hypothalamus in the body always wants to drive the weight back up. So as soon as you stop paying attention, it ends up going back up. So what does Barry need now that his weight has gone back up? So certainly, Barry needs either medication or bariatric surgery. So, and Barry has been put on the list for bariatric surgery, and he continues to, and we're working on ensuring that Barry gets the right medication, and he will continue on with his lifestyle modification also. So, in conclusion, I want to say that lifestyle management is very important. It's the foundation of all of our treatments. So don't give up trying to make those lifestyle changes, because even if you don't lose weight with a lifestyle change and you're moving more, you're eating better, you've improved your overall health. You improve your brain, you improve your diabetes, your blood sugars. So everything gets better with lifestyle, even if the weight doesn't go down. We know that medications are now available, and there are more and more effective medications coming, and certainly the introduction of liraglutide 3.0 has been an exciting time for us. As I stated, there's more medications available in the States and more that will come to Canada. But we now have some more tools in our toolbox besides just lifestyle modification. And bariatric surgery for decreasing weight and for diabetes is our most successful treatment. It's only available for patients in the significantly elevated weight range, and we know that there are some patients who cannot get it. But if you qualify for it, it certainly is the most important treatment option that we currently have. So in In conclusion, I want to say that neuroscience is what explains weight. So understanding how the brain works and the hypothalamus works is a very important aspect. That's where the set point is, and that's where our biology is always trying to drive the weight, the weight back up. So, and our biology is to defend our highest weight, and hormones adjust to try to achieve this. Treatments must work to improve your feeling of fullness. So that's important. Bariatric surgery and anti-obesity drugs act on the brain neurochemical systems, and that's how they end up working. So thank you for your time, and I hope that this has been helpful for you to understand some of the treatment options we have in Canada. I'm very positive about this field, and I'm very hopeful that we can all have a greater understanding of this field and a greater understanding of where we fit in and what it is you can do to make your weight better and to make yourself healthier. So thank you very much for spending the time with me.
Thank you very much, Dr. Wharton. Ladies and gentlemen, that concludes our webinar for today. Thank you to Dr. Wharton for sharing this information, and thank you to all of you for taking the time to join us. For those of you who use social media, you can tweet to us using #ObesityTalk, send us a message on Facebook, or simply click on the survey link that's showing on your screen right now and complete the survey. You may now disconnect and close your window browser, and we hope you have a great day.